All right, hi everybody. Thanks for being with us today and here for my riveting last hour of the day. We're going to talk about a review of fluid therapy. When I was putting this together, I thought, well, it may not be the most exciting topic, but I think it's a really good review and refresher for everyone, myself included, because it kind of brought a few things back to the forefront of my mind of, oh, this is why I do it this way when I'm treating a patient. So when we're thinking about fluid therapy, one of my mentors during residency liked to say this thing where she'd say there's three presumptions about fluid therapy. The first is that volume overload is bad. The second being inadequate volume is bad. And the third being what we conclude about the fluid balance of the patient may actually be incorrect. And I would look at her and say, well, that's clear as mud. Like, what do I do with that information? And basically the takeaway from her statement was that you need to think about what you're doing and have a very clear goal-directed approach to treating your patient, whether it's with fluid therapy or with anything else. So kind of keeping those things in mind, I think it's important that we try and think our way through a little bit of the fluid physiology. So bear with me, this isn't a ton of the presentation. We'll get into kind of the nuts and bolts of fluid treatment, but we need to kind of refresh our minds as to fluid shifts and fluid composition in the body. So I'm sure we all remember that 60% of the total body weight is water. Of that 60%, 66% is in the intracellular spaces, and 33% is extracellular water. Of that 33%, 25% is in your vasculature, so that's your intravascular component, and 75% of that extracellular fluid comprises the interstitium. Your extracellular water is what you are affecting kind of first and foremost with your fluid therapy, and your intracellular water then will kind of follow suit later on. So when we think about water movement between these compartments, there are permeable membranes that water can flow through. Between the intravascular and interstitial compartments, these membranes are freely permeable to water and small ions, so things can kind of move back and forth at will. The intracellular space is separated by a membrane that is only permeable to water, so water is the only thing that can flow back and forth readily, and transfer of solutes and ions into and out of that intracellular space is dependent upon the presence of ion pumps and ion channels that we are not going to spend any time talking about because nobody really wants that information, but they exist. So when we're thinking about that water movement, water moves freely via osmosis, which we're all familiar with. So osmosis is where water shifts to achieve an equal concentration of impermeable solutes on either side of a membrane. Osmosis is dependent upon the colloid oncotic pressure, the hydrostatic pressure, and then the capillary permeability of the vessels. And so that COP, the hydrostatic pressure, and the capillary permeability are described by this thing called the modified Starling's equation. So this is the equation here in this picture. And this is the equation that describes water movement everywhere throughout the body. And really, for our intents and purposes today, I only bring it up because you may see it in the literature, you may see it mentioned in some articles if they're looking at specific studies regarding fluid transport. So know it's a thing that exists. It describes the way water flows. And what we can take away from that and what we know based on the Starling's equation and based on how we know about fluid, what we know about fluid fluxes in the body, about 25% of the volume of any isotonic fluid we put into a patient will stay in that intravascular space after about 45 minutes. So due to just natural fluid shifting processes, that fluid's going to shift out of the intravascular space and into either the interstitium or the intracellular space. So there's always fluid shifts going on. So when we think about things that lead to that shifting of water out of the intravascular space, there's several conditions that will contribute to that. So the first is increased intravascular hydrostatic pressure. So we've got increased pressure in those vessels, and that's driving water out. Increased capillary pore size, or those leaky vessel membranes, and then decreased intravascular colloid oncotic pressure will also lead to fluid shifts out of that intravascular space. And I think, for our clinical intents and purposes, we probably don't need to look at each patient and go, oh, you've got increased intravascular hydrostatic pressure. It's probably too nitpicky, but what we do need to recognize is, okay, my patient has a condition that could lead to fluid shifting. So when we're thinking about what some of these clinical conditions are, when we're looking at conditions that could lead to increased intravascular hydrostatic pressure, so these are things like fluid overload, the patient got too much fluid, burns, SIRS processes, so our pancreatitis, our sepsis, severe gastroenteritis, multi-trauma, anything that's going to increase the pressure within those vessels. Fluid shifts due to increased capillary pore size or those leaky vessels, we can see secondary to burns or hypoalbuminemia. And then decreased COP most classically is caused by hypoalbuminemia. And I think we all know a lot of the causes that can lead to decreased albumin in the body. And so again, really, this is not so that you think about your patient and go, oh, you've got increased capillary pores. It's, you have a condition that could lead to some fluid shifting. I need to recognize that and be aware of that so I can be treating my patient appropriately, because fluids might be moving where I don't want them to go. So what can happen with excessive fluid shifting? If that fluid is shifting inappropriately or sometimes even appropriately, if we start to have too much interstitial fluid accumulation such that it exceeds the lymphatic drainage capabilities, you'll start to see the development of interstitial edema and interstitial overhydration in these patients. Other water shifts will also follow suit. So that's where you can start to see shifting out of your intracellular space and the development of cellular dehydration. These things can lead to poor perfusion, decreased delivery of oxygen, decreased tissue utilization of oxygen and glucose, and then accumulation of metabolic waste. So all of these things obviously are detrimental to your patient. They're things you'd like to try and avoid. So that's what should start to trigger you to say, okay, what kind of things do I need to evaluate in my patient to best be able to treat them with these fluids? And that brings us to the concept of perfusion versus hydration. So perfusion is the first thing that we should evaluate. In all of our patients, we're evaluating perfusion. And perfusion refers to the transport of fluid and oxygen through the blood vessels to the capillaries. And perfusion is directly dependent on the presence of adequate intravascular volume and a normally functioning cardiovascular system. So perfusion really refers to that intravascular compartment of your total body water. Comparatively, hydration, which we are also evaluating in our patients, but we're evaluating secondarily to our perfusion, hydration refers to the presence of fluid in the interstitial space. So we're referring to that interstitial water. And this hydration provides support for the cells, transport media for molecules, and provides shape to the tissues and the organs. So our perfusion parameters, as I was saying, is what we're going to be evaluating first in our patient. It's part of our primary survey. And the things we're looking at when we're talking about perfusion parameters are mucous membrane color, our capillary refill time, our resting heart rate, and our pulse rate and strength. So these are things that, we're all evaluating in our patients each and every day without even really thinking about it. It's just second nature as part of our examinations. It's important that we remember that these parameters are going to change in response to various shock stages. So a patient who presents stable is going to have very different perfusion parameters compared to a patient who's presenting in the later stages of shock. And it's pretty consistent regardless of the underlying cause of the shock in terms of what changes you may see in your perfusion parameters. So when we look at that a little bit more closely, when we think about our stages of shock, we have kind of our compensatory phase being first, early decompensatory as the patient progresses, and then late decompensatory as that patient becomes even more severely affected. So our perfusion parameters in a patient who's presenting in the compensatory stage of shock, these patients, their body is compensating, right? Hence the name. So their body is trying to make up for this hypovolemia they're experiencing, and they're going to present probably with an increased heart rate, Their mucous membranes are going to be red or injected. They're going to have a really rapid CRT, and their pulse quality is going to be bounding because their body is working really hard to circulate their decreased volume everywhere it needs to go. These patients typically also have a normal blood pressure, so we're not going to see them be hypotensive just yet. And then their level of consciousness, so the LOC, is typically pretty normal. You're not going to look at this patient and go, oh, you're the sickest of the sick, until you start to look at your perfusion parameters, and then you might be clued into something going on. As they progress into the early decompensatory stages of shock, that heart rate is probably still going to be increased. The body's still working hard, but your mucous membranes are going to be pale. Your capillary refill time is going to start to be prolonged, and they're probably going to have weak pulses. And this is where you might start to see these patients become hypotensive, because at this point, the body is still working hard to compensate, but they're not quite making it. So they're starting to shunt the fluid volume to the vital organs in the body. So you're going to start to see some increasing signs of perfusion deficits. As you progress to the late decompensatory or these end stages of shock, these patients are going to have probably a normal to a slow heart rate because their body's no longer able to compensate. These are the ones that are going to have white mucous membranes, absent capillary refill time, really poor to absent peripheral pulse quality, and pretty much non-detectable to low blood pressure. And these are the guys you're going to look at and go, yep, they are pretty sick. These might be the ones who are coming in laterally recumbent. So being able to recognize your perfusion parameters, again, is it all that important that you're able to look at your patient and go immediately, ooh, you're in compensatory shock or you're in late decompensatory shock? Maybe not, but it's important to be able to recognize kind of the spectrum of severity because that may help trigger you to say, I need to triage and stabilize this patient much more quickly than somebody else. So switching gears to hydration then, after you've established your patient's overall perfusion status, you take that next step and you evaluate the hydration. And again, this is something you're doing simultaneously. This is all part of our general physical examination. So the hydration parameters we're all familiar with are mucous membrane moisture, the position of the ocular globe, and then skin elasticity are the main things that we're going to be evaluating. So when we think about kind of our spectrum of dehydration, a patient's going to present anywhere from 0% dehydrated all the way on up to more than 12% dehydrated. And in that 0 to 4% category, you're not going to see any symptoms to suggest that this patient is dehydrated. When I was first doing my internship, I'd like to say, oh, this patient's 3% dehydrated. And my advisor would always say, well, you can't say that. You don't know that. 3% dehydrated is not a thing. So you're really not going to be able to declare that a patient is dehydrated until you're kind of reaching that 4 to 6%. And I'm seeing a question pop up here, so bear with me. I'm going to take a look at it. Oh, and it was a question for Heidi actually asking if we're going to be able to get those slides. And she will be sharing everyone's slides a little bit later on after all the presentations are done. Except now I got to figure out how to get rid of the question tab. Oh, here it is. All right, thanks. All right, so moving on. So once you get to that 4 to 6% percent point of dehydration, that's where you're going to start to see some symptoms. And the first thing you might see is some tacky mucous membranes. You've got to really kind of progress past that 4 to 6% level before you start to see more of the classic signs. So in the 6 to 8% range, this is where you're going to see your patients have loss of skin turgor, some dry mucous membranes, and if you're checking any point of care testing with the PCV total solids, they're going to be slightly hemoconcentrated as well. As you progress into that 8 to 10% dehydrated range, you're going to, in addition to your loss of skin turgor and dry mucous membranes, these guys might start to have some sunken or retracted globes, and that hemoconcentration is going to be more pronounced. Into that 10 to 12% range where not only have you lost skin turgor, your skin tent is actually probably going to be pretty persistent, and you may add dry corneas and very severe hemoconcentration to the other symptoms of dehydration. And then once you reach that past 12% point of dehydration, where these guys are just these shriveled little prunes, you actually are probably going to start to see some signs of perfusion deficits in these patients as well. So it's possible to have a dehydrated patient who still actually has adequate perfusion, but once you get past this magic like 10 to 12% mark, you just due to osmotic shifting of water, it's not uncommon that you're seeing perfusion deficits simultaneously. We do have to keep a couple of considerations in mind, when we're evaluating a patient's hydration status. It's not quite as simple as just that nice laid out table. You have to keep in mind that aged cachectic animals, they start to lose skin elasticity and body fat. And so that might make their skin tend to be excessively prolonged. So think about, your 20-year-old ancient cat who comes in with a skin tint that just never goes away, and you're like, wow, he's 12% dehydrated, but he's walking around and he looks great. It may not be that he's actually 12% dehydrated. It just may be he doesn't have any skin elasticity anymore. So you have to look at the whole picture of your patient. Conversely, obese patients or puppies or kittens, these guys might have normal skin resiliency even when they're dehydrated. So you can't just look at that one part of the picture to say, oops, you're dehydrated, or no, you're not. Again, look at all of your parameters. Panting is another thing to keep in mind. So it's going to dry out your mucous membranes and might lead you to think the patient is falsely dehydrated. And conversely, nausea, causing sometimes excessive salivation, may make you think those mucous membranes are moist and the patient is well hydrated. So again, the point is just to kind of critically evaluate each aspect of your patient and look at the big picture as a whole. So great, so you've assessed your patient, you've assessed its perfusion, you've assessed its hydration, you say, yep, you need fluids, we need to start treating you, and we've gotten to the point now where we can kind of start talking about how do we do that. There are three main phases to any fluid therapy plan. So the first is resuscitation, the second is rehydration, and the third, which also goes hand in hand with the rehydration phase, and then on its own is maintenance. So we're gonna go through each of these one by one. So starting with resuscitation, first and foremost, there are 4 steps for successful IV fluid resuscitation. The first step is to determine if there is indeed an intravascular fluid deficit. So is your patient hypovolemic? Does it need fluids? The next step is to select the appropriate fluids to replace that deficit. And you also have to pick the most appropriate endpoints and the appropriate infusion technique in order to do so. I will just add a plug here too. When you're stabilizing your patient with IV fluid resuscitation, again, look at the big picture. Maybe this patient's going to need some oxygen as part of its stabilization, as well as some analgesia as part of that basic resuscitation package for your critical patients to set you up for the most success. So step 1 of this 4-step plan. Determine if there's an intravascular fluid deficit. Is this patient hypovolemic? And so that's what we just talked about with assessing our physical perfusion parameters. This is what's going to help you determine if your patient has a perfusion deficit and needs the replacement for the intravascular volume. It's important to kind of keep in mind that hypovolemia can be an important component of most types of shock, even cardiogenic shock. So you have to always evaluate your cardiac performance in each patient. Not saying every single patient needs an echocardiogram, although, we'd love to send them all to Dr. George for that. But think about your patient critically. Think about, does it have a history of a heart murmur? Are you hearing a heart murmur? Are there syncopal episodes? Is there something that should point you a bit more towards thinking, there might be a cardiac component to this perfusion deficit, in which case that might point you down a little bit of a different path in terms of stabilization. So again, that brings me back to my point of you're looking at your whole patient and critically evaluating each aspect of their care. So after you've decided, yep, okay, my patient is hypovolemic, my patient definitely needs fluids, I don't think it's the heart, I've got to pick the right fluid to give them. And again, I think probably for most of us, this is second nature. We're not really even thinking our way through why we're doing it this way, but we'll kind of try and break it down and talk about these types of fluids and these fluid choices here as we move forwards. So our main types of fluids that we have available to us are crystalloids and colloids. So crystalloids can be used to replace both intravascular and interstitial deficits, whereas colloids work primarily for intravascular deficits alone. And there are some caveats to that, which we're going to discuss. And typically, if you're using a combination of both of them, you're going to be able to actually treat both perfusion and hydration deficits. So looking specifically at crystalloids to begin, crystalloids are water-based solutions that have small molecules that are osmotically active in the body fluids and are permeable to the capillary membranes. So great, they've got these small molecules And in the case of crystalloids, sodium provides the biggest contribution to their osmolality. So sodium is the biggest player there, and they're freely permeable to these capillary membranes. Crystalloids, there are three broad categories of our crystalloid options. So we're going to start by looking at hypotonic versus hypertonic fluids, and then we'll move into the isotonic fluid category. Hypotonic and hypertonic fluids neither of them are most commonly used as part of your initial fluid resuscitation plan. They're usually used for very specific circumstances and very specific patients. So we're not going to spend a ton of time on them. I just kind of wanted to give everyone a refresher of what they are and what their main purposes are. So starting with hypotonic fluids, these fluids have an osmolality that's less than that of the intracellular fluid, hence the categorization. And the best example is probably dextrose 5 in water. So D5W is not used during the resuscitation or rehydration phase. We're usually reaching for this after the fact to help reestablish intracellular water deficits after perfusion or hydration is corrected. And then oftentimes it's also something that we'll use just as a carrier fluid for other substances that we might be trying to give. So D5W is available to us, but we're not using it during the initial resuscitation most typically. Hypertonic fluids have an osmolality that's higher than that of the intracellular fluid. So these are things like our 7% or our 23% sodium chloride. And we'll talk about it and say, oh, I need to give a dose of hypertonic. So you might hear people talking about that. The main purpose in fluid therapy with hypertonic fluids is rapid IV volume expansion. So you're giving this really, really highly osmolar solution into that intravascular space, and due to the fluid shifting that it's going to induce, it's going to pull water from your interstitium, from your cells right into that vascular space and expand your intravascular volume very quickly. They additionally have some added effects of have some mild positive inotropy, and then through some convoluted mechanisms, they can lead to systemic and pulmonary vasodilation. So they've got some added effects. Typically, if you're using a hypertonic solution, it's being used in addition to another crystalloid. You're not giving, as high of a volume as hypertonic as you would with just typical crystalloid resuscitation. You're doing it in combination. And as you might imagine, you need to be pretty cautious with the use of this type of fluid in a patient who's already really dehydrated, because you're going to be triggering pulling of water and water shifting from that interstitial space and further dehydrating this patient then. So you've got to be cautious with their use, as well as you be cautious with use in patients who already have increased sodium levels, patients who are hyperosmolar, or those with conditions that might have literal tolerance for rapid intravascular volume expansion. So your patients with lung disease, heart disease, that just can't handle this massive overload on the intravascular space necessarily. So that brings us to isotonic fluids, and isotonic fluids are kind of the bread and butter of fluid resuscitation. These are the ones we're most familiar with. These are the ones we're reaching for right away in our toolbox. So the isotonic fluids are broken down into replacement crystalloids and maintenance crystalloids. Replacement crystalloids are the ones I think, again, we're most familiar with. So that's our plasmolite, our lactated ringers, our NORMAR, and our replacement crystalloids have a sodium concentration that's similar to the extracellular space. And that makes it the ideal crystalloid for the resuscitation and rehydration phase, because it's going to provide intravascular volume without inducing these quick and rapid massive fluid shifts. Maintenance crystalloids have half the sodium concentration as the plasma. So with that in mind, they're not truly isotonic. Typically, you're adding 2.5% dextrose to bring it up to that isotonic level. And they're used most commonly to replace daily sensible and insensible water and electrolyte losses. And I will say that maintenance crystalloids, I think, are things that in clinical practice, even in a critical care setting, I'm using very, very infrequently. Most of the time for your ongoing fluid needs, replacement crystalloids are very sufficient. So breaking down our types of fluids a little bit further, we'll start by looking at our isotonic options. So if we're looking at our LRS, our plasmolite, and our NORMAR, these are all buffered isotonic crystalloids. And when we're looking at the specific buffers, P-lite and NORMAR are buffered with acetate and gluconate. Acetate and gluconate are metabolized by the muscles and then with some metabolization by the liver, compared to LRS that's buffered with lactate. And so the lactate metabolism occurs in the liver, and there's this caveat to the usage of LRS in patients with liver disease. You may see it stated, you know, don't give LRS to patients with liver disease because they can't process the lactate and you can lead to significant shifts in your serum lactate concentration. And I think that's, you know, it's definitely a true statement, but that's probably not the case for your most typical liver disease patients. It's safe enough to use in patients with liver disease. It's typically in those who have very, very severe liver dysfunction, bordering on liver failure, or maybe if you've got a different option other than LRS, choose that instead. But if LRS is all you have and it needs fluids, I don't think that it would, you know, I don't think it's something where you have to be terrified to give it LRS because of the lactate. It's just something that theoretically we kind of need to keep in mind with that LRS. When we're looking at the sodium concentration of these solutions, again, you know, they're pretty similar. LRS, P-Lite, Norm R are pretty close to each other. The potassium concentration between the three is pretty similar, and it's, you know, fairly negligible. And then the difference with LRS is it also has a little bit of calcium, you know, not enough calcium to clinically impact your calcium, you know, when you're measuring it, but something to keep in mind, particularly in patients that you may be giving a blood transfusion to. So the calcium present in LRS can precipitate with the citrate anticoagulant in a blood product transfusion. So most commonly you're just turning off your fluids, so it's not something you have to think about, but if for some reason you're giving them both together, you can lead to precipitation. So it's even more important to turn off your LRS if you're giving a blood transfusion. Normal saline is our other isotonic replacement crystalloid option. You can see it's got a little bit of a higher sodium content, at 154. It doesn't have any potassium or any calcium, and it's not buffered, so it's a little bit acidic. Normal saline certainly can be used for your initial fluid resuscitation plans, although typically I'm picking a buffered solution for most of my patients unless they have, you know, some certain specific conditions. The first condition that I'll reach for normal saline in for my fluid resuscitation is in those hypercalcemic patients. So you might say, oh, well, it doesn't have any calcium, I'm not giving any more back, neither do P-Lite or Norm R, so I can't give those. And you certainly can, but the benefit of normal saline in your hypercalcemic patients is that it's an acidifying solution, and by promoting that acidosis, that actually helps promote calciuresis, so it might help the body excrete that calcium a little bit more readily. So I might be reaching for normal saline in those patients across the board. I know that when I was originally being taught veterinary medicine, we would say, okay, we'll use normal saline in blocked cats because it doesn't have any potassium and these guys can be really hyperkalemic. And that's, you know, certainly not wrong, but there's been well, I don't know if it's fairly recent anymore, probably 8 years or so ago, there's a study looking at specific fluid types in treating blocked cats, and they concluded that there's really no significant difference in outcome in potassium levels in particular in blocked cats treated with, you know, a potassium containing solution versus normal saline. So pick what you have available. Moving on to our hypertonic saline, I think the big thing to look at there is look at that sodium concentration. You know, it's got 1,200 milliequivalents per liter in a hypertonic solution compared to that of your isotonic replacement solutions. So you can see where that's going to promote very significant fluid shifts through that massive load of sodium that you're entering into that intravascular space. Conversely, you've got half-strength saline, which is then hypotonic, that only has 77 milliequivalents per liter of sodium, and that's going to also induce some fluid shifts for the opposite reason of your hypertonic. I will say that I don't use half-strength saline very often at all. It's something that I will use if we're treating patients with very specific sodium imbalances in particular, but it's probably not something that in clinical practice I reach for frequently. And then D5W that we talked about previously, it's hypotonic. There's nothing in it, right? It's water. So we know that it exists and we're using it as kind of our adjunct fluid for down the road after they've been resuscitated. So that brings us to colloids. It's kind of our whirlwind through crystalloid therapy. Our other option that we have to reach for are colloids. So colloids are isotonic fluids, so they are isotonic, but they've got significant concentrations of really large molecules that are bigger than the capillary pores that contribute to the colloid oncotic pressure. And when we think about our colloids, we have both natural and synthetic colloid options. So our natural colloids are basically our blood products, our whole blood, our plasma, our concentrated albumin, and they achieve their contribution to colloid oncotic pressure due to the proteins that are present within these solutions. If we're giving these products with the sole purpose of maintaining our colloid oncotic pressure, it's really not practical to use strictly a blood product for that. The volume that you would need to infuse to actually have a true effect on the colloid oncotic pressure is really high. So there might be a volume tolerance issue. And then also it may be cost prohibitive if you're just having to run constant plasma. So there are very specific situations where I will reach for plasma as a maintenance fluid, but it's typically pretty uncommon. Just a note on concentrated albumin. Concentrated albumin certainly can be used in patients who need it. It's just important that we're trying to use the canine lyophilized albumin product whenever necessary, because there have been very severe allergic and anaphylactic reactions documented in dogs to the human product. So concentrated albumin is an option, but you should be using the canine option if you need it. And that's all we're going to say about the blood products, because transfusion medicine is a whole nother lecture unto itself, but they exist as natural colloids. Synthetic colloids are the ones that we're using most frequently as part of our fluid resuscitation plan. And the ones that are commonly available are the hydroxyethyl starch products. So these hydroxyethyl starch products help maintain the intravascular colloid oncotic pressure because the molecule size within the solution is just way too big to pass through the normal capillary pores. So you put it in the vessel and it actually stays in the vessel, as opposed to our crystalloids, which are going to do a lot of fluid shifting like we discussed. Colloids will help expand the plasma fluid volume by about 100 to 150% when you're giving them. So they've got a pretty significant effect. And typically you're giving them with isotonic replacement crystalloids to help restore your intravascular volume. They also are pretty persistent. They will stay in the vasculature for an extended period of time. And studies have shown that about 38% of hydroxyethyl starch products are going to be within the body after about 24 hours of infusion. They're broken down, these molecules are broken down by alpha amylase, and the alpha amylase is breaking it down sequentially. It's not like it's all broken down at once. So what you have is this ongoing supply of osmotically effective molecules until that alpha amylase is able to chew these molecules up small enough to exceed that renal threshold and then be renally excreted. So they're persistent in the vasculature as well. So the one that is labeled for veterinary use is vet starch. Vet starch may be what we have on the shelf to use it with our patients, although you can also use the HES starch products as well. I'm just going to spend a little bit of time looking at the label on vet starch, because I've reached for it and said, okay, I'm going to give it to my patient, but there's all these numbers. What do they really mean? So the first thing in a label on any hydroxyethyl starch product is your concentration. So you're going to have this 6% here, and concentrations range from 3% to 10%. And the big takeaway from that is the higher the concentration, the higher the impact on the intravascular volume effect this product will have. The commercially available products, I think, are pretty typically 6%. 10% solutions in the literature have been associated with more adverse outcomes. So I've not used a 10% solution personally. The next thing on the label is the type of hydroxyethyl starch it is. So it says hydroxyethyl starch. We've got hetastarches, hexastarches, pentastarches, and tetrastarches. They name it based on what the molar substitution is. So this molar substitution, which we'll speak about in just a second, tells us, this molar substitution of 0.4 tells us that vet starch is a tetrastarch product. And then the next thing on the label is your molecular weight. So this 130 here indicates the molecular weight of the vet starch. And the takeaway from that is the higher the molecular weight, the longer it will persist in the vasculature. So for the points on this slide, the higher the concentration, the higher the impact on your intravascular volume status, and the higher the molecular weight, the longer it stays in your vasculature. And then the next thing on the label is that molar substitution, which we briefly talked about. And it gets pretty nitpicky, but basically what it's referring to is the average number of these hydroxyethyl residues on this big molecule. And the number of these residues dictate how easily amylase can get to that molecule for breaking it down. So it's really quite fascinating. But basically what you need to know about that is the higher the molar substitution, the longer that persists in the intravascular space. So these numbers tell us how long this product is going to stay within the body. And then the last thing that impacts the pharmacokinetics of hydroxyethyl starch products is the C2 to C6 ratio. That's not on the label. I think you find it like in the product handout or something like that. And that takes this molar substitution a whole step further and looks specifically at the pattern of substitution. And as everything else has kind of been trending towards, the higher the C2-C6 ratio, the slower the molecule breaks down. So there's products that have been formulated to have a very high persistence and a long persistence in the body. So they sound like great products, right? They're going to stay in the body for a long time. They're going to increase your colloid oncotic pressure. They're going to increase your intravascular volume. They're wonderful. We should use them for our fluid resuscitation. But of course, nothing can be as simple as that. Hydroxyethyl starch products have been documented with fairly significant rates of complication. Significantly in the human literature. The biggest thing that we have seen documented is renal injury, and there's a number of different proposed mechanisms as to how these products can induce renal injury. They think it might be osmotic nephrosis. They think it might be hyperoncotic acute kidney injury. You're not really sure, but they've been shown to cause the potential for significant renal injury, as well as having a pretty significant impact on coagulation through a variety of mechanisms. So much so that the FDA has actually given a black box warning on hydroxyethyl starch products in the human world. And this black box warning on all these products states that in critically ill adult patients, including septic patients, so the patients that you may think would benefit the most from a product that would increase their colloid oncotic pressure, use of these products in multiple studies has been shown to increase the risk of mortality and increase the incidence of need for dialysis. So maybe we don't really want to use them. And so I was asking one of my friends who's an ER physician, I said, well, if that's the case, do you ever use a colloid? Like, why do they exist? And her answer was basically no. When she's resuscitating a patient in her ER, she's using crystalloids because they do less harm than colloids. And if the patient needs blood, give them blood. I said, oh, well, you guys just made it a whole lot more simple than we have in veterinary medicine. Because in veterinary medicine, I think we're still reaching for colloid products. We're still using them. I'm still using them because the complications that have been reported in our veterinary patients haven't really been to the level that was documented in the human world. You know, we've extrapolated a lot of their warnings to our patients and we've expanded upon our own studies. I mean, for the last couple of years in DACVECC, there's, study after study looking at the impact of certain percentages of colloids on clotting times and things like that. And what we're finding is that, yes, we have seen some variable incidents of complications in our veterinary patients with hydroxyethyl starch products. With regards to clotting times, a lot of the studies show that, yes, you can see an impact on clotting times, but number one, it's usually transient, and number two, it's typically not clinically significant. And then there's contradictory studies looking at the potential for development of acute kidney injury. So I think kind of the takeaway from it is we're still using colloids in veterinary medicine, but I do think that the trends have changed. When I was first being trained, I was using colloids very frequently as part of my initial resuscitation for most patients. And I've kind of moved away from that over the years to the point now where I'm using them actually, fairly infrequently. not because I'm, scared to use them, but because maybe I'm thinking about my patients a little bit more critically and saying, you're somebody with some underlying kidney disease, or you're someone with a predisposition to coagulopathy. Maybe I'm not reaching for them right away. Although there certainly are instances where I will still use them, and I do think they have a place in our resuscitation toolbox. So after we've picked our fluid, we know if we're going to use a crystalloid, we know if we're going to use a colloid, we have to decide what we're going to do with that fluid. We're not just giving the patient a fluid bolus and saying, okay, I gave a fluid bolus. We actually have to have a goal for what we want that fluid bolus to achieve. And that brings up the concept of resuscitation endpoints. So step 3 is picking these most appropriate resuscitation endpoints. When we're thinking about resuscitation endpoints, we're either targeting normal endpoint parameters or near normal endpoint parameters. You may see these near normal endpoint parameters also referred to as low normal or permissive hypotension. In the literature, these terms are pretty interchangeable. So normal parameters are just that. I'm going to fluid resuscitate my patient back to normal. I want him to have a normal blood pressure. I want him to have a normal heart rate. Near normal endpoint parameters are near normal. You're going to accept a little bit of tachycardia. You're going to accept some degree of hypotension, and we're going to kind of pick that in very specific patients. Got a question popping up here. So the question was, is there any place for colloids in any route besides intravascular? And the answer to that is no, they're not given subcutaneously. I would imagine that that probably would be somewhat irritating for one, but number 2, their main effect is in the intravascular space. So they act in that intravascular space to maintain the colloid oncotic pressure. They don't have any effect on your interstitial fluid status because they're not leaving the vasculature. So you're using them with the sole purpose of replacing intravascular volume deficits. That's a good question to think about with those for sure. All right, so going back to these resuscitation endpoints, we talked about our normal endpoints, and targeting normal endpoints is appropriate in patients with underlying systemic inflammatory response syndrome conditions. So your pancreatitis, your gastroenteritis, patients with septic processes, you want to fluid resuscitate these guys back to normal. You want to give them the best perfusion that you can give them given their condition. Near normal endpoint parameters, we pick in a very specific subset of patients. So the first group of patients that would probably benefit from near normal resuscitation are those patients who are bleeding. Because if you're giving them large volumes of fluids to get them back to normal, you're increasing that hydrostatic pressure in their vessels very quickly and potentially very extensively. And this increased hydrostatic pressure can disrupt the clots and it can actually lead to worsened hemorrhage. So I think the classic example of this is your hemoabdomen that comes in with, a heart rate of 200 and a systolic blood pressure of, 60. It would be great to get that patient back to a normal status. You can say, okay, good, I'm replacing your volume. But if I'm giving them fluids to the point where they've got a normal heart rate and blood pressure, I might actually be blowing off some clots that have been struggling to form, and then I could create this vicious cycle of bleeding and rebleeding. So we're going to be more conservative and target near normal endpoint parameters in these patients. Other patients that benefit from near normal endpoint parameters are those with other conditions that could be worsened by sudden increases in hydrostatic pressure. So if you're giving them a lot of volume, you're increasing that hydrostatic pressure, you can lead to fluid shifting, like we had talked about way back in the beginning. And patients with cerebral pulmonary edema or lung disease in general, oliguric renal failure, these guys might not tolerate large volumes of fluids to get them back to normal, be pushing fluids out of the vasculature very rapidly. So there's that subset of patients in which you might actually be okay with a heart rate of 160 and a blood pressure of 80. It's kind of counterintuitive to how you may want to resuscitate a patient, but there's a certain subset where you can actually feel pretty good about achieving that. So the last step in resuscitating your patient is choosing your fluid infusion technique. So it's not as simple as it used to be where you'd say, okay, I'm giving a shock dose of fluids or I'm giving a quarter shock dose of fluids. There's a little bit more reasoning behind how much fluid we're giving to these patients. So we have the large volume fluid infusion technique and the small volume fluid infusion technique. So large volume fluid infusions are appropriate for dogs with those SIRS conditions, dogs with metabolic conditions or surgical problems, compared to small volume fluid resuscitation, which is what should be employed in all cats. Cats should just get small volume fluids, don't give them big fluid boluses, and dogs who require those near normal targeted endpoints. So I'm not just trying to get them back to near normal, I'm also doing it very slowly and incrementally. So when we talk about what volume that really implies, starting with large volume fluid resuscitation in a dog, because again, let's not resuscitate a cat with large volume fluids, they're so sensitive. So large volume fluid resuscitation, when you're starting with your isotonic crystalloid, that refers to about 20 to 30 mils per kg in a rapid infusion. And rapid infusion really does mean rapid. So it's probably over about 15 minutes, no more than 30 minutes of starting that bolus. It's not just, put the bolus on the pump and walk away, because depending on your pump, that might take an hour, and that's not a fluid bolus. So you're giving it rapidly. If you're using a hydroxyethyl starch product, large volume infusion refers to about 5 to 10 mils per kg, again, as a rapid infusion. Compared to small volume infusion, so you can use this for both dogs and cats, and these are those dogs that you're going to be targeting near normal endpoint parameters for typically. You're starting with a 10 to 15 mil per kg rapid infusions. So still fast, but it's a smaller incremental bolus of your isotonic crystalloid. And then if you're using hydroxyethyl starch, probably about 3 to 5 mils per kg in a rapid infusion. So you've got large volume versus small volume resuscitation options available. So we'll take a minute to talk about cats in particular, because I'm saying don't give them large volume fluids because they're sensitive. And that's because they are. Cats, aren't necessarily small dogs when it comes to a lot of things, fluids included. And so cats presenting in circulatory shock present typically pretty hypothermic, bradycardic, and hypotensive. And the hypothermia that they experience in particular really blunts the normal vasoconstriction that would occur in the body in response to all of the circulating catecholamines. So these cats are predisposed to being vasodilated and hypotensive as they come in. And so what that means is, because this hypothermia is playing such a significant role, you start with giving them small volume fluid boluses, and then you apply heat. And typically what we'll see in cats is a hypotension that's actually responsive after their body temperature exceeds about 98 degrees. So once their body temperature is back to normal, you may see that hypotension resolve without further fluids. So that's why it's important to start with small volume fluid boluses and target near normal parameters, because if you're giving them large volume fluid boluses and trying to achieve normal parameters, number one, you might not get them to a normal parameter because they're so cold still. And number two, you could very readily fluid overload them and develop things like pulmonary edema and pleural effusion, because as you warm them up, all of these fluids are going to extravasate. So you have to be a little bit more cautious with fluids in our cats. Speaking along the same lines of heating these cats up, I think it's very common. We'll have a cat come in and their body temperature is 96, and well-meaning people say, "Ooh, do you want me to get it a bear hugger? Do you want me to warm it up? It's really cold." And my answer is always, you can put a blanket on it, but I don't want to apply any active heating, because application of surface heat can cause local vasodilation. And so you can vasodilate these patients even further if you're trying to warm them up, and then kind of crump out your circulatory system altogether. What little bit of pressure they may be trying to maintain, you could just vasodilate totally away. So typically the rule of thumb is, don't start your active warming until you've also started some initial fluid infusions to help provide some of that vascular support. So you have to be a little bit cautious with that as well in cats. So again, the main point in cats, best to use small volume infusion techniques, whether you're reaching for normal or near normal endpoints, and be cautious with when you're applying heat in these little guys. So throughout this process of resuscitation, continuous monitoring is super critical. It's not just, like I said, put it on the pump and walk away. It's really a stand by the cage approach. And you should be checking these endpoint parameters between each fluid dose. So you give a large volume fluid dose, rapid infusion. After you've given it, you're checking your endpoint parameters. Have I achieved them? If I have, great, I can move on. If I haven't, What do I need to do next? Why haven't I achieved those endpoint parameters? And the most common cause of persistent hypotension and persistent poor perfusion in these patients is really just they haven't gotten enough fluids. It's an insufficient quantity of fluids administered. So if you haven't reached your endpoint parameter, maybe you try a little bit more fluid. And if your perfusion parameters improve, okay, you're still probably on the right track. You can continue cautiously with your continued fluid resuscitation. However, if you're not reaching your targeted endpoints, whether it's normal or near normal, after giving multiple titrations of fluids, you've got to start looking for reasons why. Why does this patient have non-responsive shock? Typically, that multiple titration of fluids refers to, and here's where our traditional shock dose comes back in, to about 60 to 90 mils per kg per hour of an isotonic replacement crystalloid, plus or minus about 20 to 30 mils per kg of a hydroxyethyl starch product if you're using one in that patient. If you're not reaching your endpoint parameters after that, you kind of need to start looking to figure out why this may be going on in your patient. So again, you're taking that step back and you're looking at the big clinical picture, because there are, a million different causes for why this patient may be presenting with non-responsive shock. So repeat your physical exam. Look at your point of care lab work. Maybe you've got a hypoglycemia, maybe there's a hypocalcemia that needs to be addressed. Maybe this patient does have an underlying cardiac problem, or maybe it's anemic. There's a long list of things that can be at play. If you're kind of going down that checkbox and you're not finding a clear reason that you can readily correct, then this may be the patient in which you need to reach for vasopressors. And at that point, or at any point in the process, you can certainly give us a call. I'm happy to talk you through cases like this. I love cases like this, or just send them our way and I'll try and figure out why they're not responding either. But let's say your patient has responded. You've successfully fluid resuscitated it. You've fixed your perfusion deficits. It's back to a normal volemic state. Great. We can move on in our fluid therapy plan and move on to that next step of rehydration. And when we're moving on to our next step of rehydration, the first thing to do after you fix the perfusion is reassess your hydration parameters. Because remember, most of our crystalloids that we're giving during our resuscitation phase is going to move into that interstitial space. So a patient that you thought was 10% dehydrated when it first came in, after you fluid resuscitated it, maybe it's 7% dehydrated or something like that. So taking that step back and rechecking your hydration parameters and reassessing how dehydrated you think this patient is at that point in time is that first step into developing your rehydration plan. After you've decided that, so you have to think about the volume of fluid you're going to give them. You have to think about how long you're going to give that fluid over and what type of fluid you're going to use to rehydrate your patient. We're all familiar with this formula, so when you're calculating the volume of fluid you want to give, you take your body weight in kilograms, times it by how dehydrated your patient is, and that's going to give you your volume of your interstitial fluid deficit. So we've got our 20 kg dog who's 10% dehydrated, gives you a 2-liter interstitial fluid deficit. If you've got an 8 kg dog who's 5% dehydrated, you've got a 0.4 liter deficit or a 400 ml deficit that you know you have to replace. So how quickly are you going to give that back? If it is a very acute loss situation, the textbooks will say you can give that fluid back in about 2 to 4 hours. That's going to yield a pretty robust fluid rate. I'm pretty comfortable with high fluid rates, but sometimes even replacing things over 2 hours makes me nervous. So you may be able to pick more towards the longer end of that spectrum. But the whole point is, if it was lost acutely, you can give it back acutely. You just have to be watching them very closely. If they've lost fluid more chronically, or if they're at high risk of interstitial fluid overload, you want to give it back over a little bit longer period of time. So again, the textbooks are going to say about 6 to 12 hours. I probably skew on the longer end of things of that for chronic fluid loss. And again, the whole point is you're frequently reevaluating this patient. You're reevaluating its clinical hydration status. You're looking for any continuing losses and ongoing demands to make sure you're giving it the appropriate fluids or as best you can. What fluid type are you going to use? This is where our isotonic crystalloid replacement crystalloids are still at play. So you can use your LRS, your P-Lite, your Normar. You're using your crystalloids to replace your interstitial fluid deficits or your dehydration. Colloids, as we've mentioned, don't do anything for interstitial deficits. They affect the intravascular volume only. So while you're rehydrating your patient, and then after you're done rehydrating your patient, you also need to account for the maintenance fluids that the patient needs. So these two steps kind of go hand in hand, and then maintenance is a separate category on its own after the patient is rehydrated. So there's a variety of formulas for calculating maintenance fluid needs. So there's the quick and dirty of about 40 to 60 mils per kg per day, or you can use your RER formula, so the formula for a less than 70 kilogram patient or a greater than 70 kilogram patient. You kind of pick your poison. They'll give you fluid rates that are in the realm of each other. There's definitely going to be some discrepancy between the formulas, but you're going to be sort of in the same neighborhood at least. It's important that you account for these maintenance fluids during your rehydration phase. So you're not just rehydrating your patient, you're also accounting for the maintenance and their ongoing needs. And it's important that you remember ongoing losses. So does your patient have a condition, one of those conditions that's going to lead to intravascular fluid shifting and loss of fluid from the vasculature? So do these patients have fevers? Do they have polyuria or tissue inflammation or something like that? That may trigger you to say, okay, they need maintenance, but they probably need even a little bit more to keep things going. So going back to our 20 kilogram dog who is 10% dehydrated, we're going to say this guy presented for acute vomiting and diarrhea. And we've already established that he's got a 2-liter fluid deficit. We're going to fix that deficit over about 8 hours. We're going to be a little bit more conservative. So we're going to fix it over about 8 hours. So that means we need to give back 2,000 mils over 8 hours for a fluid rate of 250 mils per hour for those 8 hours. But we also have to remember he needs maintenance fluids. Doesn't need just what we need to give him back. We have to account for what he needs ongoing. So depending upon the formula you choose to use to calculate your maintenance requirement, so whether you're using your RER formula or a mil per kg per day formula, that's going to give you a daily maintenance requirement. So if you're using the RER, this guy needs about 28 mils per hour. If you're using 58 mils per kg per day, 40 mils per hour are his maintenance needs. So again, they're not the same, but they're in the same neighborhood. So you're going to add that to your rehydration rate for those 8 hours. So you take the 250 mils per hour he needs to be rehydrated in addition to 28 mils per hour. That's going to give you a fluid rate of 278 mils per hour over those 8 hours. He's a pretty sizable dog. It's a reasonable fluid rate to give him back. Although definitely, I think we've definitely had nursing staff go, that seems like a high fluid rate, which is number one, great because they're thinking about their patient critically. And number two, we're recognizing that this guy has some ongoing fluid needs that we're still seeking to meet. The fluid type you're going to use for your maintenance fluids, most commonly it's still reasonable to use your isotonic replacement crystalloids. Our sick patients in the hospital typically have some ongoing losses that they need, but you may be able to reach for maintenance crystalloids in these patients as well. Just it's probably more convenient and also probably more economical just to have one type of fluids on the shelf in the hospital. So I don't think it's something where I would say everybody needs to have maintenance crystalloids available. But monitor these guys really closely during their fluid therapy. You should be reevaluating their fluid needs at least twice daily. We're evaluating them at every shift change, so at least 3 times daily. And then oftentimes during the course of my shift, I might evaluate a patient's fluid needs 4 or 5 times, depending on their critical nature. Make sure you're accounting for the fluid volume of any CRI drugs they're getting. If they're getting large volume IV drugs, so something like IV doxycycline that has to be diluted to like 1 million milliliters, that should be something that you factor into your patient's maintenance fluid needs. So that brings us to monitoring. We're watching these patients very closely, not just during the resuscitation phase, but also during the rehydration and ongoing fluid replacement phase. So kind of at the cage side, you're able to evaluate very quickly your physical examination findings. What are your perfusion and hydration parameters? I'm checking these on my patients, sometimes multiple times a shift, and adjusting accordingly. Blood pressure also can provide really important information, whether it's direct or indirect, whether it's your systolic versus your MAP. Our patients are typically getting a Doppler systolic blood pressure, standardly every 6 hours. If they're more critical, it could be more frequent, every hour, every 2 to 4 hours. So you can use that information and adjust things on the fly, depending on how your patient is responding. Weight is also another important indicator of fluid balance. You can kind of use it as a sentinel for fluid shifts in the body, because we know about a 1 kilogram change in body weight is roughly equivalent to about a 1 liter change in total body water. So weigh your patients fairly frequently. So ill patients, we're weighing maybe every 4 to 6 hours. If they're a stable patient, maybe they only need to weigh every 12 hours. But you can use that information, particularly the trends in that information, to help you kind of get a better idea of what your overall fluid balance in that patient is. Point of care testing also can be very useful in helping monitor your patient's fluid status. So your PCV solids, you're looking at it and going, you're still really hemoconcentrated, you might need more fluids, or you're really hemodilute, maybe I'm pushing you a little too hard on the fluids. It's also important to not just say, oh, you're hemodilute because I'm giving you too much fluids. Also keep in mind, if both are decreased, you should keep hemorrhage in the back of your mind, depending upon your patient's presenting complaint. With acute hemorrhage, however, your pack cell volume can be normal to even increased, because in response to the sympathetic stimulation induced by the hemorrhage in the body, splenic contraction is going to kick out a transient number of red blood cells and then transiently increase that PCV. So it may not be decreased immediately. So an initial low total protein without an equivalent PCV drop could be a telltale sign of hemorrhage, and should just kind of tune you into saying, I should pay close attention to this patient moving forwards and make sure we're not seeing that actually turn into a problem. Lactate, metabolic acidosis, increased base deficit, whatever you may have available in terms of point of care testing in your hospital, these parameters can be really helpful to give you some clue as to if there's ongoing tissue hypoxemia or hypovolemic shock. Lactate in particular has been looked at fairly extensively in the literature, and lactate clearance, so taking what your lactate was on presentation, how quickly does it go back to normal? That rate of lactate clearance in certain conditions has actually been associated with some prognostic indicators. So keeping an eye on that lactate. If it was elevated to begin with, I'm at least going to do a check or two to make sure it goes back to normal. If it's staying elevated, I'm going to be looking for reasons why that might be the case. In patients on longer-term fluid therapy, and even on those presenting for resuscitation, watching your electrolytes is important. Your potassium is something that you can supplement fairly readily. Just be really cognizant that you're not bolusing from that bag of fluids after you've given them any additives of potassium, because you could accidentally bolus a cardiotoxic dose. So your bag should be very clearly labeled with any additives, so nobody's going to see that and get confused. So watch that potassium, and then watch your sodium, especially in patients on chronic fluids. If they're in the hospital for several days, you may start to see some sodium shifting. Lots of times it may not be clinically significant, but it may reach the point where it is clinically significant, and you can use it as an indicator of change in your overall intracellular volume. Urine-specific gravity is something else you can monitor. By itself, it's not a great indicator of overall fluid status in a patient who's on fluids, but kind of roughly you can use your spec grav to say, okay, if my spec grav is normal to even high in a patient who's on fluids, might tell you that you're still losing more than you're putting in. So that may be a trigger to have you reassess your fluid plan. It's not something I'm using routinely, but there are certain cases where if I'm scratching my head trying to figure out where we're at with fluids, it may be something I do a quick check on because it's non-invasive and inexpensive. And then along the lines of urine output is something else that in specific situations can definitely be very beneficial in helping you understand your fluid balance. So patient with a UCAth in, normal urine output in a well-perfused patient should be greater than 1 to 2 mils per kg per hour. It's very dependent on the presence of adequate renal blood flow, which is dependent on your mean arterial pressure being greater than or equal to 60. So if your UOP is dropping below that normal benchmark, or if your outs are you're exceeding your ins, or conversely the opposite, you may be able to adjust your fluid therapy accordingly. And I think the most common example of this is we're using it in blocked cats as we're adjusting their fluids based on what's coming out in their urinary catheter bag. And then I'll just briefly talk about these advanced techniques of fluid monitoring. And really, I'm going to mention CVP, tissue delivery of oxygen, pulmonary capillary wedge pressure, and cardiac output, simply because, again, people love to study these in the veterinary literature. The research papers are all about this. You'll never use these in clinical practice. I'll never use these in clinical practice. Maybe CVP, but that's a controversial monitoring technique as well. So know that they're out there. Know that you may see some of these more advanced techniques mentioned in the literature, but don't worry about them really for all intents and purposes. We monitor these patients so closely because fluid therapy, certainly isn't benign. There's definitely the possibility of complication development. And the first and probably the most common thing we can see is the development of fluid overload. So these guys can present with really mild signs to begin with. So it may be something as simple as serous nasal discharge. You might see a little bit of chemosis. Your nurses may say this dog needs to go out every single hour or he's flooding his cage. So polyuria may be a trigger to say, maybe I'm giving him more fluids than he needs right now. Or hypothermia and shivering. So some mild symptoms may develop to begin, but as things progress, you may see more moderate signs develop. So that skin might start to be gelatinous. You might just start to see some tissue edema. You can see some tachypnea, development of third spacing, so pleural effusion development or ascites. If you're really overhydrating and perfusing that GI tract, that also can prompt diarrhea, nausea, vomiting. An acute weight gain should also maybe be a trigger for you to think about your patient's fluid status. Whoa, did he get too much too fast? And watch that weight trend as part of your monitoring technique. And then presenting all the way with the very severe symptoms of fluid overload. So things like exophthalmos, are you having a patient who's really hypertensive? Have you pushed them into pulmonary edema? Are they really depressed? These are all things that may develop, and the first thing that we should do when we're suspicious of fluid overload is turn off our fluids, reassess our patient, our physical exam parameters, reassess some of our point of care testing, and then decide, are these symptoms because of fluid overload, or is there another underlying cause that's causing the change in these patients? And then treat them accordingly. And you can't really treat all of these patients with some blanket or uniform treatment because each patient is an individual. So some patients, they may need a diuretic, other patients may not, other patients may be able to go back on fluids. So it's going to be very case and patient dependent as to what you do next in cases of fluid overload. And fluid overload isn't the only thing that we see with fluid therapy complications. It's probably the most common, one of the first things that may develop, but we also need to keep in mind that we're giving them fluids that contain some degree of electrolytes, and we're inducing water shifts. So electrolyte alterations are certainly possible. That's where monitoring your potassium, monitoring your sodium can be really beneficial and help you decide what, if anything, you need to adjust in your fluid therapy prescription. We also can lead to an anemia. Not that, the fluids make the body lyse red blood cells or anything, but we can unmask an underlying anemia. We can cause them to be very hemodilute. So I think a good example of this is, we go back to our 20-year-old kitty with chronic kidney disease who's here for fluid diuresis. If he presents with a PCV of 22% and maybe a solids of, 9 or 10, I'm going to tell the owners, well, right now he's got a mild to moderate anemia. When I give him fluids and get him back to being appropriately rehydrated, so once he's euhydrated, we're going to have caused those red blood cells to kind of shift back out and go back to being kind of at their normal state, and he might be even more anemic. So maybe we're going to see this guy's normal state be at 15%, 16%. And so I will warn them this is a possibility, and sometimes we see these patients need things like blood transfusions. So keeping an eye on your PCV solids in patients who are at risk of this is important. And then renal injury and coagulopathy, as we talked about, higher risk with your colloids. You're not seeing these most typically with crystalloid therapy. So it's really important to monitor all of your patients really closely due to the number of complications that may develop with fluid therapy. So that kind of brings us back to, my mentor's points at the very beginning of this is, well, too much volume is bad, but so is too little volume. And you might be totally wrong with how you assess your patient. And hopefully, if you're thoughtful and goal-directed in how you're approaching each of these patients and then how you're subsequently managing them, you'll probably be able to kind of fight against those presumptions and do the best for each of your patients. So starting out by each patient assessing their perfusion and rehydration, really get a good feel for where they're at clinically, resuscitate that patient first and foremost, and to help guide you during that resuscitation, you have to critically assess your endpoint parameters and your infusion technique and frequently come back to that, recheck that, make sure you're on track and adjust accordingly. If they're resuscitated, great. You get back to that point then where you can rehydrate them and you can maintain them. And then the big thing is just monitor, monitor, monitor. Monitor them really closely and adjust. And sometimes that's multiple times in a shift, multiple times during their course of hospitalization. But fluid therapy is something that is really important and is really kind of the mainstay of how we're treating a lot of our patients. So I think we need to be thinking about it very critically and kind of knowing why we're doing what we're doing each step of the way.